one of the funniest stories, and it happened years ago, and it taught me to be very careful with what you say to people. It was a patient who was having a hard time going back to work, and he was on some medicines. So he said he couldn't work because the medicines made him sleepy. Well, I told him to, change it out for something like a leave. Well, the way I said it, I get a phone call from the employer saying, Della, the patient said you told them not to go back to work, just to take a leave. Well, when I'm thinking back on my conversation, that's what I said, to take a leave instead of the medicine. And they thought I meant take a leave from work.
My PA and I see 35 patients in a half day, so 60 to 70 in a full day of office. And some of those, it's a mixture of old patients, new patients, work comp patients, all those sort of things. Summarize the important way of handling work comp patients and ending up with the best result is how we communicate. And if that's electronic, if that's by voice, if that's face-to-face with a nurse case manager, certainly with the patient, that's the way it needs to be.
I have a patient with low back pain, and I did a diagnostic test, and her pain got really good. It got much better. And I went to do a second one, and they told me no, because it was so good, the response, that we want you to go ahead and treat, right? Do the final treatment. But they told me, but you can only do it for half of the patient's problem. You can, I need to do radiofrequency ablation of 3 levels, but they told me we're only going to approve 2 levels. So I know where the problem is, I know how to treat it, but now they're telling me just treat half. When we make decisions as far as treatment is concerned with patients, we are obviously doing what we think is the best for the patient. And if there's any doubts or any concerns, we would love to have input or be called or to explain what we're doing and the reason we're doing it, and as opposed to being denied or being approved partially for our treatment plan.
That's a tricky question when you're trying to figure out how to cost contain, because I usually don't think about the cost when I'm taking care of a patient. I do understand that some interventions are more expensive than others. Certainly surgical intervention in spine is among the most expensive in all of healthcare. I think the key is to remember that we're trying to get a patient to an endpoint in workman's compensation is trying to get them back to their pre-injury level of function. So I think it's important to try to categorize patients in very quickly. So one of the ways I do that is to try to get my imaging studies if the patient seems to not be getting better as quickly as I expect. So I like to get high-quality imaging studies, whether it be x-rays in our office or high-quality MRI or CT myelogram, to make a good decision for my patient. So once we get to that point, I can get to a therapeutic endpoint very quickly and categorize a patient as non-surgical or surgical and give them their options and go from there.
If you're not communicating with everybody, you're losing and you're getting off track, because a caseworker or management or a caseworker may be teach you things about where the patient's going, what they're doing, how they're acting, and it's very helpful to me to talk to them. Many times they can make modifications in their work status that once you explain to them what they can and can't do, that make a difference in getting them back to work earlier, or they make modifications in behavioral things from the staff or from a supervisor that's putting a little bit too much pressure on that makes the patient better.
My specialty is limb length and deformity correction, which is the multi-operated patient, the non-union, the malunion, the fail fixation, or the infected bone. One of the average types of patients has had 4 doctors and 6 previous surgeries. I'm about 15 to 20% workman's comp. It's my 17th year in practice. I prefer it when the nurse case manager comes to the appointment, because any issue with paperwork or return to work or getting a test scheduled or getting a secondary procedure scheduled seems to go much easier.
My biggest roadblock is the timeliness of authorizations. I find out that either we send authorization requests and they fall in the black hole, or maybe the authorization request has been worked on by the nurse case manager or the adjuster, but unfortunately that information has not been relayed to us. So therefore, scheduling subsequent appointments don't come as timely as they should. My preferred method of communication is email. And something that I have learned is that everyone doesn't have email, and it's hard to believe that we're in the 21st century and they don't have email. But that is my preferred method. That way I can answer those emails from my phone, from my laptop at home, or from the computer here at Pinnacle.
Speed is a big deal, and how much, I'm not going to throw anybody under the bus, but the fact that there's so many middlemen really hurts us a lot now. Because if you want to talk about how quickly you get things authorized to get folks into therapy, or extend therapy or get conditioning, or even if it comes to a TENS unit or something from home or custom splint, there are a lot of delays in the system now in getting those things authorized. Because when the networks are in the middle, nobody knows who's talking to whom, and it takes it even longer.
A lot of times I wonder why we don't have a job description ahead of time. We have several patients that come in that are upset about going back to light duty. So we would like to get a job description ahead of time, maybe like with medical records when they come. We have several, like I said, patients that come that are not wanting to go back to work, and the physician is asking me, well, what do they really do? So job descriptions would be very helpful when we get medical records ahead of time as well.
The one thing I would change about the work comp payer system is the delay I see happening right now with the work comp payments. I think it takes up sometimes to 3 months to get payment, and I do realize the volume of work comp has increased so much. That could be part of the problem. But that's about the only negative thing I hear about workers' comp pay is the delay in receiving the check.
So work conditioning versus work hardening is actually a funny thing to talk about, because we had this big debate, and a lot of people are asking, what's the difference? And we want to do this one, or we want to do that one. And technically, by definition, work conditioning is you're conditioning the entire body to get back to work. So for instance, if you had a shoulder injury and we're working on your shoulder, we need to get you stronger. You've been out of work, everything is deconditioned. So we'll have you on the treadmill, we'll have you squatting, whatever the needs are to get you back to your full duty. It doesn't have to be specific, though, to the task that you do at work, whereas work hardening, by definition, has to have job simulation. So not many people around Metro Atlanta do job simulation. It's not feasible. So almost all of us do work conditioning, and there's this huge debate about, do you do this or do you do that? But the codes are the same for both. It's a work hardening / work conditioning code in terms of CPT code, and they're both paid the same. So it cracks me up that that's a big debate.
I want to teach them that, unfortunately, with physicians, patient care is always going to come first. Returning them to work, they're going to do that, but the patient care will come first. So to be a little patient, to approve what we request if they find it reasonable within a timely manner. The focus and the goal of the practice is to return patients to work as soon as possible and to return them to work as healthy as possible.